Hello and welcome to EJC News Focus, this month from ESMO 2012 in Vienna. There were more than 1,200 presentations, so I asked local ESMO officer Christoph Zielinski to pick out some of the highlights.
We have a very important presentation on crizotinib in non-small cell lung cancer overexpressing ALK and comparing this with conventional chemotherapy. And it turned out that this concept of crizotinib being, which has been shown before to be quite valid, also holds true in comparison with conventional chemotherapy regarding progression-free survival and also response rate, which is with crizotinib impressively better than with conventional chemotherapy.
So the difference is sufficient for people to sit up and take notice?
Oh, definitely. Definitely. This is something which is one of the major highlights of this conference, showing that targeted treatment is truly a very important advance in the treatment of at least this type of disease. Once you know what makes the cancer truly function as a malignancy. So once you target the crucial point in signal transduction, then you really have an optimal outcome in treatment. Rather, when comparing when you just target a target which would be not that decisive, then we do see a lot of other broad limitations. But classically, when you look at imatinib, when you look at crizotinib, when you look at also the targeted treatment with EGFR mutation with erlotinib or gefitinib, then you find how impressively this influences the biology of the disease.
What about HER2 positive breast cancer?
Even more so this is true with HER2 new positive patients, of course, in breast cancer. That is something where we have experienced here quite a major, impressive corroboration of our strategies, because usually trastuzumab, which is targeting HER2 positive breast cancer, is being given in the adjuvant phase for 1 year. 1 year was the gold standard since trastuzumab was introduced in the adjuvant treatment of HER2 positive breast cancer. But the question, of course, lingered, particularly since a study which was published from Finland showed that shorter duration of trastuzumab might suffice. The question lingered, is shorter treatment better? Or another question, of course, which was around, is longer treatment better than 1 year? And it turns out in both of these trials that the 6-month duration of treatment versus 1 year did not meet the non-inferiority criterion, at least for now. And the 2 years prolongation versus 1 year did not ameliorate the results. So we are on very safe ground saying today, and as of today, that 1 year adjuvant treatment in HER2 positive breast cancer is the ideal duration for this patient subgroup.
But it's not the end of the road for 6 months of trastuzumab.
It's probably not the end of the road because, of course, this was an analysis which is still going on and where we will have to particularly wait for the subgroup analysis, because we have the impression when you look at the curves, we have the impression that one or the other subgroup might benefit from 6 months, whereas another subgroup does not benefit from 6 months and rather needs the 12 months duration of treatment. So we're eagerly really waiting for the subgroup analysis, hopefully statistically so valid that we can really draw conclusions from that, and then maybe use 6 months in a certain subgroup of this disease.
So the key point in the success of both crizotinib and trastuzumab is the previous work on cancer biology.
That is right. We see this more and more often. Just take the melanoma work on the BRAF mutation. And how important it is even to influence downstream signals like the MEK pathway, where you would say you do have a benefit once you have identified the crucial target and are able to influence this in such a way that the crucial target is being kicked out, sort of, biologically at least, and is continuously neutralized, thereby stopping to continue to give the growth signal to the cell.
That ties in quite nicely with the French work on cancer genome analysis.
That is right. The genome analysis in breast cancer which comes from the Institut Gustave Roussy, and is, as far as I understand, a national endeavor. It's very interesting because these patients with breast cancer, metastatic breast cancer, are biopsied, and then the genome is being analyzed. And according to the result of the genome analysis, the chemotherapy is replaced by a targeted treatment, which would result from this genome analysis. Now, these are very interesting concepts which have been pursued for the last couple of years. There was a very important paper by Von Hoff and co-workers in the Journal of Clinical Oncology very few years ago, already opening the arena for this. And we do find that there are targets which are being identified by this approach, which again identify treatments which you would never expect to be effective in a certain disease. That is quite impressive. This trial from France was truly groundbreaking because it shows first that the feasibility is there, that you can make the genome analysis, and then you could start slowly translate this into the clinic. Now, why I say slowly has a reason. Because of course we have to analyze first whether this concept and the application of the findings from the genome analysis truly results in a better outcome for patients.
So there's lots of very exciting science at ESMO 2012. Are there take-home messages that would be relevant right now?
Oh yes. We are going in an extremely fast pace. The little steps that we're taking are being replaced by larger steps that we're taking. And the second message is there should be no such trial anymore which does not include biomarker analyses, and where we should not try to understand the biology of disease and what we're doing with it by treating patients with this diagnosis.
Would you offer any words of caution in interpreting the data presented here?
Not everything that is statistically significant is clinically relevant. And that is something important, that you have to weigh this and look at that, whether statistical differences, once there's only enough, high enough percentage or high enough number of patients who are being included into trials which result in small differences, is truly something which is clinically significant on an individual basis. And that is something where the science of oncology again turns into an art.
So a note of caution amid the excitement of new discovery. And with thanks to Christoph Zielinski, that's it for this month's EJC News Focus.